to discuss SaferMedsNL and our second campaign, which is focusing on the deprescribing of sedatives for primary insomnia. And I'd like to extend a big thank you to everyone who's attending, as well as to the College of Registered Nurses for the opportunity to deliver the webinar. Before I dive in, we're going to go to the next page. So hopefully some of you have heard about SaferMedsNL, but for those of you who haven't, I'll just run through a little blurb of what we are and what we're doing. So we are a public awareness campaign. It's focusing on the safe and effective use of medications. And our goal is to decrease the unsafe, unnecessary, and harmful medication use across the province. And we hope to do this through raising awareness of the benefits and harms of medications, provide resources to both patients and healthcare providers on ways to reduce potentially inappropriate or harmful medications, as well as promoting meaningful conversations between patients and their healthcare providers to ensure that medications are continued when they're necessary but stopped when they're no longer needed. And so we are a partnership between the Provincial Government, Newfoundland and Labrador, Memorial University School of Pharmacy, and the Canadian Deprescribing Network out of the University of Montreal. However, we have a steering committee which is comprised of clinicians, patient advocates, academic researchers, community organizations, healthcare provider associations, who are all working together to help steer our program and achieve our mandate of improving medication use. So why are we doing what we're doing, I guess? So while we are trying to reduce the use of inappropriate medications, I would prefer we say that we're promoting the appropriate use of medications. And so to do this, we kind of look at two things. One would be the number of medications somebody is on, because as you know, the more medications somebody is taking, it increases their risk for side effects or for drug interactions, the prescribing cascade, as well as we look at the benefits and harms of medications. So just to give some context to Newfoundland and Labrador, I don't know if you'd be surprised if I told you that 80% of seniors over the age of 65 in our province are taking 5 or more prescription medications. That compares to the national average of 66%. And then if we increase that number to 10 medications, prescription medications, we have about 40% of our population of seniors who are taking 10 or more, compared to the national average of about 25%. And unfortunately, that number only increases with age, with, this is a Canadian stat, but with about 39% of Canadian seniors taking 10 or more medications. So while the number of medications certainly does increase our risk, it's sometimes 10 or more medications is necessary. So it's more so about the utility and the effectiveness and the benefit of these medications. And so that kind of leads us into the next slide, which, why are we looking at sleeping pills or sedatives? And so for the purposes of this presentation and for our entire campaign, I guess I just want to emphasize a couple of things. One, that we're looking at the use of sedatives for primary insomnia. So we're not looking at the inappropriate use or the appropriate use for conditions such as anxiety, depression, other sleep conditions like restless legs, or alcohol detox. So we are focusing on the inappropriate use for insomnia only. And also, throughout the presentation, you'll probably hear me flip back and forth between using sedatives and sleeping pills or benzos. And I think one of the reasons for that is I do presentations for the public as well as for healthcare providers, so I often time use the word sleeping pills, and I flip back and forth all the time. But again, our program, our campaign is focusing on benzodiazepines, Z-drugs, as well as trazodone. So if you hear me refer to sedatives, I'm kind of encompassing all of those in one. So why are we looking at sedatives? Well, the thing is with sedatives, it comes down to the benefit over the risk of sleeping pills. And the thing is with sleeping pills, they carry a whole lot of risk with really very modest benefits. They're only effective for a very short period of time for insomnia, about 4 weeks, but they continue to cause many problems in the long term, especially for the elderly. So what are some of these risks that we're referring to when we talk about the risk for sedatives? So there's an increased risk of physical dependency, cognitive and functional impairment. There's an increased risk of drowsiness and daytime sedation. and of course, the increased risk of falls and fractures. Just a word on falls and fractures, in particular for seniors. So falls are the leading cause of injury hospitalizations for seniors across the country. They lead to about 9% of emergency room visits. 30% of seniors living in the community in Canada will be institutionalized within 1 year of a hip fracture. And 20 to 30% of those patients who have a hip fracture usually die within 1 year after the fracture. So these are some pretty staggering stats, and it all translates into you know, a lower quality of life and, of course, a strain on the healthcare system. So I think putting, you know, giving perspective to patients on not only does it increase your risk of falls, but what can happen after the fact, kind of gives some, you know, more emphasis on why it's important that we really assess the benefit over the risks. So I'll speak a little bit more to those harms in a bit. So as I mentioned, it really has to do with balancing the benefit and the harms of medications. Over time, things change, and what was once a benefit may no longer be a benefit. And like I said, while there may be a modest benefit for a very short period of time, they do stop working and they become harder to wean over time. So the effect wears off, yet the risk of adverse effects remain the same. And so this is the reason why we are looking at sleeping pills and targeting sleeping pills for insomnia, because there really isn't a whole lot of benefit, but there's a whole lot of risks. So are they really that bad? Let's have a closer look at some of the risks and benefits. So number needed to treat. 1 person out of 13 will experience one of the following benefits. So this is referring to benzodiazepines in particular, but about 35 minutes of extra sleep, and it might help them get to sleep about 14 minutes faster. If you're looking at Z drugs, it might help with about 22 minutes faster getting to sleep, and they don't even know if it will help them get any extra sleep. So, you know, and that's only 1 person out of every 13 people that are taking a sleeping pill would receive one of those benefits. Having said that, number needed to harm. So we have 1 person out of every 6 who take a sleeping pill who would be harmed. And this includes delayed reaction time and impaired cognition. So the risks, for example, there's a 50% increase in falls. And this refers to not only long-term use, but after PRN use, so as needed use, as well as if there is other sedating agents being used and medications being used at the same time. There's a 2 times increased risk for hip fracture, and there's a driving, so equivalent blood alcohol level is equivalent to a blood alcohol level of 0.06 to 0.11%. So sleeping pills, we often refer to how bad they are for the you know, older adults because they have an increase for risk. But I think this would be a good tagline for sleeping pills in general because they are bad for all ages. So we are concerned about younger patients as well, especially if, you know, for example, we have concerns about driving safety, impaired cognition, the daytime sedation, that residual sedation that can impair judgment, delay reaction time. So for example, we may have patients, you know, a new mother, for example, that may be having difficulty sleeping and may be taking, you know, a sleeping pill, but she may be unaware of some of the, you know, some of the residual effects that may remain by taking a sleeping pill. So just a word about other medications besides the ones that I've encompassed, so like trazodone, benzodiazepines, Z drugs. So Z drugs would refer to, in particular, to zopicone or zolpidem. Those would be, when we're referring to Z drugs, those are the 2 that we're talking about. So neither quetiapine nor trazodone are indicated for sleep, and those are associated with adverse effects such as falls and fractures. We often see people using over-the-counter sleep remedies, so diphenhydramine, Benadryl, diphenhydramine, or Gravol. And again, these have a whole lot of side effects, but they have equally powerful cognitive effects compared to benzodiazepines, so they wouldn't be recommended. And then if you look at melatonin, there's not a whole lot of evidence for melatonin for its use for chronic insomnia. And if you just have a look at the some of the benefits, the possibility that it will reduce the sleep latency by about 9 minutes and increase total sleep time by about 8 minutes. However, there are some significant side effects such as headache, confusion, irritability, depression, and stomach upset. So, you know, it's probably not the most effective medication to help with chronic insomnia. However, that's not to say some patients may not, try it, but it's just to have a little note there on some of the benefit they may receive if they do decide to try it. So I'll skip this and jump right into the next slide. So we're going to go on to the slide that said, did you know? I'll come back to the other slide. So just an interesting fact that I found really surprising when I first learned about it and read about it. So the risk of a motor vehicle accident is the same for both driving under the influence of alcohol as it is for driving the morning after taking a sedative medication. So I found that really surprising when I read about that because, I knew that there would be some residual sedation, but I didn't realize how much. So this was from a cohort study done in Washington State, and I referenced the study there if you want to look into it some more, but they did about 400,000 patients they followed over the age of 21, and they were looking at temazepam, trazodone, and zolpidem. And the end result was that there was equivalent risk for motor vehicle accidents, driving under influence, as it was for taking driving the morning after taking a sedative medication. So I don't think that's something a lot of patients realize, and it's certainly something that stands out, and it's an important thing that I think they are aware of. The clinical pearl. I just wanted to have a note there saying, that tolerance does develop to the sedating effects of medication, which is why we usually only have therapeutic effect for anywhere from about 7 to 28 days. We say less, up to about 4 weeks. However, tolerance doesn't always develop to the anxiolytic effects of sedatives. And I think this is important to note because there are people who are going to prescribe benzodiazepines for anxiety, and they may have a long-term indication for it. So this would be something that wouldn't constitute dependence, whereas somebody who's using it for insomnia may end up becoming dependent on it and developing tolerance and needing a higher dose. So just something to point out about the tolerance developing to the sedating effects, but not necessarily to the anxiolytic effects. All right, so we know that they can be a problem, so what can we do about it? So this brings us to deprescribing. So in general terms, deprescribing refers to a planned and supervised process of stopping a medication or reducing the dose of medication that is no longer of benefit or that could be causing harm to a patient. And so that could be different for every single person we see. What might be benefiting one person may not benefit somebody else. But the important thing to emphasize is that deprescribing, and I emphasize this when I'm talking to the public, because deprescribing is really intended to be a shared decision-making process with healthcare providers, and it's a planned and supervised process. So patients aren't on their own. They'll be followed. They can connect back with their healthcare providers. They can ask questions. They can help them, reduce any fears they may have about withdrawal effects or any fears they may have about rebound insomnia. So it's really important, I know when I'm speaking to patients, that I make them aware of that fact, that it is supposed to be a shared decision-making process that takes into account, what they assume to be important for them, consider to be important for them. So this here is the deprescribing.org benzodiazepine deprescribing algorithm, and essentially it's a step-by-step process on how to determine if somebody should be deprescribing after sedating medication. And so obviously the first thing we're going to do is a two-page thing. So this is the first page is the algorithm, and then the next page goes through the back half, which is the next slide, goes through just some points to help guide clinicians as we deprescribe somebody off of a benzodiazepine. And so we'll look at this in more detail, but this is one of the tools that is available either through deprescribing.org or also available on the SaferMedsNL website. If you want to access that, it's available for download. On deprescribing sedatives. So deprescribing can encompass a whole lot of different options. So it can include abruptly stopping a sleeping pill if the person is using it for about less than 3 weeks or so. Tapering the dose slowly. You can recommend cognitive behavioral therapy. We can combine tapering with cognitive behavioral therapy. We can also reduce the use with the following approaches. So we may just use a lower dose compared to baseline, and we may use it as needed. I also have down there is the possibility of providing a substitutive therapy. The Canadian guidelines do state that melatonin is something that can be, substituted for some people. And so I guess the important thing here is that the ultimate goal may be to, eventually have somebody completely off their sedating medication. However, what deprescribing from one person may end up just being a lower dose for the time being, or using it only as needed. So it really needs to go according to that particular patient and what they feel they're comfortable with, and what is best in the best interest for them. We're revisiting the deprescribing algorithm there. So the first step will be to determine the eligibility for deprescribing of a benzodiazepine. So the first thing we want to look at is why the patient is taking sedating medication. So is there a history of anxiety? Is there a past psych consult? Did they start it in hospital for sleep but then it never got stopped? Was there a period of grief 10 years ago when somebody belonged to them passed and they were experiencing insomnia? And so there's a lot of things to consider when we're deciding whether or not the person should be a candidate for deprescribing. We might look at whether or not the medication is being taken only at nighttime, or is it being taken multiple times per day. So we want to get a really good history. But once we've determined that there's no other, sleep disorders, there's not any unmanaged anxiety, depression, physical or mental conditions, and that the benzodiazepine is effective specifically for anxiety, then we can look at the insomnia. And as long as it's being used for primary insomnia or for insomnia where the underlying comorbidities are managed, we can recommend deprescribing. And so the recommendations for the Canadian guidelines say that if somebody is over the age of 65 years of age, regardless of the duration of use, we would recommend benzodiazepine tapering, and that they should be avoided altogether as a first-line therapy for insomnia for older adults. And for those adults aged 18 to 64, we recommend a slow taper for anybody that's been taking it for longer than 4 weeks. Patient is a candidate. So once we know that the patient, is a candidate and is an appropriate patient to recommend deprescribing, then we really want to discuss with that patient any potential risks, benefits, what the withdrawal process and the tapering process is going to look like, and what they can expect. And we really want to encourage them to express, any perspectives and concerns they might have, and this might be an opportunity to help clear up some, misconceptions, because oftentimes this is going to be a barrier to whether or not that person can successfully taper. So we really want to open up that communication line and have them express what some of their concerns might be. So one thing I found that stand out is often putting things in perspective. I mentioned this earlier because oftentimes patients don't necessarily bring it back to them. They might think, oh, that won't apply to me. But I oftentimes find it helpful to ask somebody what they would vision their life like if they were to experience a fall or a fraction, and that kind of brings it, to real life and brings it into perspective for them and helps them really engage in that conversation about it. So that's just one little thing that seems to work well. And so it's really just about choosing that right approach for each particular patient. Some patients may, be wanting to know the benefits and the risks. Some might want to explore what are the potential options if I am going to stop my benzodiazepine. And then I'm going to speak to it a little bit later, but we do have a brochure that can be used as a form of communication and as a conversation starter with between healthcare providers and patients, so that if we have a patient in front of us, and they're not quite convinced that they want to stop their sleeping pill, we can provide them with this brochure, and maybe at their next visit they may want to revisit and have that conversation again. So I'll go into that a little bit more detail in a few minutes. Just a word on realistic sleep goals. So with age, sleep patterns change naturally, and less time is spent in deep sleep. There are more frequent nighttime awakenings, therefore leading to more napping during the daytime. So it is normal for older adults to go to bed later but wake earlier compared to when they were younger. And I think that is important to reiterate that sleep requirements change with age. Many adults, believe that they need to get 8 hours of sleep per night. However, really most adults only require about 5 to 7 for optimal functioning. So that is an important thing to mention when we're looking and asking people about their sleep and is their sleeping pill working and how are they sleeping. It's on tapering schedule. So as I mentioned earlier, tapering deprescribing strategy should be offered to all eligible patients. So if 65 years and older, they should be tapered slowly, regardless of time of use. And then for patients 18 to 64 years of age, after about 4 weeks, they should be tapered slowly. Having said this, there are no trials identified which compare different tapering strategies. So we really don't have great evidence about what method would work well, in terms of tapering, and it really depends on the particular patient and how they're responding to the taper. So the algorithm recommends deprescribing about 25% every 2 weeks, then 12.5% every 2 weeks, and then near the end we'll have some drug-free days. So that was shown as one successful method. In the next couple of slides, I've added a couple of links to some really good, the Canadian Deprescribing Guidelines, as well as the Centre for Effective Practice of Managing Benzodiazepine Use in Older Adults, and both those resources give different options for different tapering schedules, and so you can have a look at those, because the Canadian Deprescribing Guidelines, I think, have a list of 10 different options, so I didn't go into all those, but the link is there. So yes, I just kind of went on that. So as I mentioned, tapering needs to be individualized. That is one way that the algorithm suggests, the 25% every 2 weeks, decreasing by 12% once at about 50% of the original dose. However, it really can be adjusted once the patient, is followed up and can let you know how they're feeling. Are they experiencing any withdrawal effects? And if they're not, how's their sleep and how are they feeling? And those are both the links to those resources. So it is really important that patients are informed about what to expect with the withdrawal and rebound insomnia. So, they may experience mild withdrawals such as anxiety, sweating, GI symptoms, and rebound insomnia. But generally speaking, these are mild and short-lasting, so anywhere from a few days to about 4 weeks. However, tapering of the medication should help, at the very least, minimize the severity of these symptoms. Severe withdrawal symptoms such as seizures are really not something that we would be concerned about if we're tapering off a medication, as long as, if somebody is slowly tapered off and it's not abrupt stopping, and if they're not, if they don't have a seizure disorder. So that's not something we're really concerned about if we're going to taper off slowly. And we want to make sure that we counsel patients to avoid OTC sleep aids such as sleep ease, because these aren't recommended, and we're really not trying to replace the sedative with another sedative. And then I'll speak to these a little bit more, but some sleep hygiene and some relaxation tips would be really helpful for them to kind of get them through that period of withdrawal. So warm baths, cool room, aromatherapy, or anything that they find relaxing, really. That's going to be depending on them. We're on to the Empower brochure slide there now. So this is the brochure that I alluded to earlier, which can be used as a conversation starter between healthcare providers and patients. So it's an evidence-based patient brochure to help patients make decisions about their sleeping pills so that they feel informed to ask questions. So it is based on the Empower randomized trial. So that's the Eliminating Medications Through Patient Ownership of End Results. So it's an RCT, a randomized control trial, and essentially it tested the patient education tool on benzodiazepine. So it tested this brochure here on benzodiazepine. It took place in Montreal and involved 30 pharmacies. About 300 participants who are chronic users of benzos, aged 65 years or older. And after a 6-month follow-up, 5% had discontinued their benzodiazepine in the control group versus 27 in the intervention group. So individual patients that received this brochure, there was a 27% of those people, had stopped using the benzodiazepine after 6 months. And none of them required any hospitalizations, although there were people, about 38%, who had reported withdrawal symptoms. And so essentially, the purpose of this brochure is really to, like I said, help patients become informed about their medication, and really gives them, it goes through some true and false questions, some facts about sleeping pills, and really get them thinking about whether or not their sleeping pill is providing benefit to them. And then it provides some tips on how to sleep, on how to relax without using medication. So this brochure is available on our website to download and print. We also will have it available to order online soon. If those of you who are familiar with the PPI campaign, and I'll speak to that in a few minutes, but the proton pump inhibitor campaign for last year, we had the tools available to order. You could go online and order the tools, and we'll do the same with the Empower brochures for sleeping pills as well. Speaking to the Pharmaceutical Opinion, I wanted to include this here, just going to go through this briefly, but essentially what this is a tool for communication between pharmacists and healthcare providers. So you may receive this in practice from a pharmacist, and you can certainly use it as a form of communication if you would like to as well. And it just goes through, some different, why we would recommend somebody stop their sleeping pill. The conversation's been had, they've been provided with written educational materials such as the Empower brochure, and it looks like they're a good candidate for deprescribing, and here's here's the information. So that's just wanted to make you aware that that's something you may see in practice. It is available also on our website. The thing is, we're getting people off our sleeping pills, but that doesn't necessarily help them with their sleep. So it's kind of like a net benefit because, the sleeping pill is probably not helping them sleep any better, but nonetheless, they may still have those underlying reasons of why they're not sleeping well. And so, we need to make sure that we address that as well. And so that kind of brings us to CBTI, or cognitive behavioral therapy for insomnia. And while that's another CE webinar all to itself, we do have a brochure that is available called the How to Get a Good Night's Sleep Without Medication. So that will also be available to order free of charge, and we will ship free of charge as well. And that kind of goes through step-by-step for some sleep hygiene, as well as a step-by-step instructions on sleep diary, sleep efficiency, and cognitive behavioral therapy. So that's a good tool to use with our patients. So in terms of sleep hygiene, with sleep hygiene at the top, generally there's, one thing I found for sure is that I take things for granted that people might know about sleep hygiene and what they shouldn't do or what they should do before going to sleep. And so generally we recommend that they sleep less than 1 hour a day, between 1 and 4 p.m., no later than 4. They max of 1 to 2 drinks, at least 4 to 6 hours before bedtime, using their bed for intimacy and sleep only, avoid exercise and caffeine too close to bedtime, and they recommend that if you're in bed for any longer than 15 minutes that you actually get up and then try again in a few minutes later. And then, of course, mindfulness, meditation, and deep breathing can help with that as well. So the brochure goes through a list of different things that is helpful to kind of give the patient so they have it with them. And then, as I mentioned, it goes through the CBTI. So few other things. I just have a couple of slides there with some tools that are available free of charge. So they're apps, and while I know that some patients aren't, really technology savvy. There are definitely patients who might really like an app like this. So this is CBTI Coach. It's free of charge. It can help patients can store their information on their sleep diary, and they can bring it to the next appointment with somebody. So that's one thing I wanted to point out. And then there's a couple of meditation apps as well that are free of charge that might be of use to some patients. Because we are stopping their sleeping pill, and oftentimes they want something tangible, something that they can do to replace it. So this is at least some things that we can offer that, might work. So, as I mentioned, all of our resources are available on SaferMedsNL.ca. In addition to the algorithm and the Empower brochure, as well as the How to Get a Good Night's Sleep Without Medication brochure, there's also some other links to the Canadian guidelines for deprescribing sedatives, as well as there's a whiteboard video on how to deprescribe sedatives and a couple of other patient handouts that are available. So please explore our website. And so just to speak to our actual campaign, so we are currently in the process this year of doing the Sleep and Pills campaign, and so this is our first approach. So this will be the kind of the design of the campaign. You'll start seeing this around town, hopefully, and around the province. So what we're doing is targeting some of the different harms. So, for example, the risk of falls, the risk of motor vehicle accidents, memory loss, cognitive impairment, and stuff like that. So this is the first of the many different designs you'll see. And then for anybody that may be familiar with our PPI campaign, which we will be continuing into this year. So it's not that we've forgotten about it, but it's not our focus. We are kind of switching gears and going to be focusing on sleeping pills. However, our heartburn medications is still something that we're going to be promoting, and so that some of that material is still available as well from our website. There's our contact information, so please feel free to follow us on Twitter and Facebook and share our posts, because we're really trying to spread the word of appropriate medication use across the province, and so any way, shape, or form we can do that, we appreciate it. And finally, I just want to leave this up to acknowledge all the different people that are working together to promote safe and effective medication use across the province. And, I think it's going to take a collective effort for us to see change, and everybody has a role to play, whether, if we are prescribe or dispense medications, if we speak to patients and families, if we're part of a healthcare team, if we're committed to preventing falls and memory problems, if we teach or write newsletters or arrange webinars. So, we all have a role we can play to improve medication use, and in particular sleeping pill use. So I just want to acknowledge all these people who are helping us spread the word. And yeah, that's it. Thank you so much.